For the next portion of our presentation, we're going to dive into geriatric shoulder pain a little bit. So first, the prevalence of this condition. One study I found showed that 31% of adults, older adults, have complained of severe shoulder pain. And how they described this shoulder pain is that it was anything that caused a limit in their function. So whether it was getting dressed or honestly any activity of daily living, if there was pain that inhibited their movement in doing any of those activities, that is what they described as severe shoulder pain. It also stated that shoulder disorders are more common in women than in men. So next, on to the common causes of shoulder pain. So kind of your more general ones that affect any population will affect the geriatric population as well. So your rotator cuff tendonitis, rupture, subacromial impingement, as well as issues at the AC joint. They say OA there, so obviously your osteoarthritis is going to affect this population more, just because they've had the years and years of usage. But we have to remember when dealing with this population, their muscles are weakening, their bones are weakening. So when it comes to the tendonitis and the rupture of the rotator cuff, we really have to be careful when dealing with this population because of the increased frailty, as well as being aware that this could be a potential issue for them. Also, you have fractures. When we talked in the hip fracture lecture, the bones are weakening. Falling on an outstretched hand could easily fracture the humerus, and then it's frozen shoulder. Another article I found had this chart in it. I thought it was really interesting to just be able to easily delineate kind of between frozen shoulder, OA, rotator cuff tears, and then tendonitis. And just, I'm not going to read it, but just looking at it in general, as long as we remember our key special tests for ruling out the tendonitis and the rotator cuff tear, we really should be able to identify pretty easily. And then there's some good info there with the range of motion and the different special tests. We should be able to identify the actual issue that is going on with these patients. And then frozen shoulder, that chart says X-ray, but then obviously we know like the capsular pattern, and we can work on that to potentially, diagnose or say they have symptoms in line with frozen shoulder. So now on to risk factors, kind of as I said above: gender, surrounding muscle strength. As we age, our amount of muscle mass just goes down. And so that support for the joint just decreases a little bit and isn't able to support it as much. Diabetes, age, obesity, waist to hip ratio, metabolic syndrome are all also risk factors. So really, the more unhealthy the population is and the more comorbidities, I know it's not rocket science, but those patients are going to be more susceptible to pain, just kind of coming on. And so finally, for treatments of shoulder pain, I found one article that discussed non-surgical repair of rotator cuff tendon ruptures. It said that it had kind of mixed results. They had positive results in the elderly population, but then some also had to get surgery as well. The article discussed the use of corticosteroids, hyaluronate, and PRP, which I know we discussed in one of our classes. But this article mentioned that there's still no evidence to support actually using these techniques, and that it actually was beneficial. Kind of like when I was talking above with the comorbidities, it's super important to assess how the comorbidities are going to affect their ability to heal and recover from surgery. And kind of jumping down to the last point there, that was a main decision maker for having a reverse total shoulder arthroplasty compared to a normal one, is if there was the tendon rupture, which is the main thing, as well as if there are fatty deposits in the area. That could force them to do a reverse. And then this last point, I found a case report. It was a PT working on, I think it was around a 40-year-old guy. So obviously not quite in the geriatric population. And in his conclusion, he stated more research would need to be done to validate what he found in this case report. Obviously, it's the lowest level of evidence. But he was able to do focused exercise. I think he said about 15 to 20 minutes a day. Well, not bad and easily doable with the HEP, as well as like manual glides of the shoulder. And he was able to drop his pain. I think it was around like 20 to 30%. So it's definitely, motion is lotion, right? Like the more your joint moves, the more synovial fluid gets created. And I mean, that decreases as well as you get older. But I think that could be some valid evidence to say, hey, maybe we need to emphasize the movement of the individual joint more as we treat in the geriatric population. So that might be an interesting thought to move forward as we discuss more of these treatments. Oh, and that was specifically for osteoarthritis as well, which is obviously heavily impactful in this population. So on to the next section now, guys.